Hello everyone. My name is Simiran and I welcome you on behalf of Voice of Healthcare to a virtual session on the occasion of World Breast Cancer Research Day 2025. We are honored to welcome you for today's panel discussion titled Under 40 and Diagnosed Breast Cancer in Young Women. Breast cancer is often perceived as a disease affecting women in later in life, but a rising number of cases are being diagnosed in women under 40. These young patients face unique medical, emotional, and social challenges, from aggressive tumor biology and fertility concern to navigating careers, relationship, and family life while battling cancer. So, this makes this conversation on research awareness and holistic care especially urgent. And for this discussion, we are privileged to have with us esteemed panel of experts who have dedicated their careers in advancing cancer care and research. I would like to introduce Dr. Suveera Dhup, Chief Operating Officer and Indian Cancer Genome Atlas. Welcome to our show, ma'am.
Thank you.
Thank you so much for joining us, ma'am. We have Professor Dr. Surendra Nath Senapati, President of Association of Radiation Oncology, who have vast experience in shaping radiation oncology. Welcome to our show, sir.
Thank you.
Thank you so much for joining, sir. Dr. Sharad Desai, President of the Indian Association of Surgical Oncology and Director of Mahatma Gandhi Cancer Hospital, Miraj, Maharashtra. Welcome to our show, sir.
Thank you and good evening, everybody.
Thank you so much for joining, sir. And now, to shed light on how science, clinical practice, and patient support must come together to address the breast cancer in young women, let's begin with our discussion. And I would like to ask my first question, Dr. Suveera. Ma'am, with ICGA's work in cancer genomics, how do you see genetic research shaping early detection and treatment pathways for breast cancer in young women under 40?
Thank you, Simiran. Thank you for the question and thank you for inviting me to this important discussion. Let me begin by stating a key fact. In India, breast cancer presents at a very young age as compared to the Western populations, often between 35 to 45 years, which is more than a decade earlier than the Western countries. These early onset cases tend to be aggressive. They have higher grade of tumor, more lymph node involvement, and a greater likelihood of hormone receptor negative subtypes or triple negative breast cancers as we popularly read them in the newspapers. And all these types of subtypes of breast cancers have a limited treatment option and poor prognosis. And that's where the genetic and the molecular research becomes a game changer. At ICGA, or the Indian Cancer Genome Atlas, where I work, we are building an India's first comprehensive multiomics platform, integrating DNA, RNA, protein, which are the nucleic acids, with clinical profiling and outcomes. And in fact, last year we launched our first comprehensive cancer multiomics data portal, actually on breast cancer patients, starting with first 50 longitudinal studied cases and now expanding over. And before somebody asks me, why am I talking about genomic data sets? It's because most of our clinical guidelines in India are still based on Western genomic data sets, which do not actually reflect the unique genetic architecture of Indian populations. For example, way back in 2019, a very important study which was published in an Indian journal said that 44% of the BRCA1 and 78% of the BRCA2 mutations that were studied way back then were novel to Indian patients. They were not found in the global databases like TCG or UK Biobank. And that matters because it means that we are often risking or missing the high risk individuals in Indian populations, or maybe
We cannot hear you.
or people in general at inherited risk. It would help in tailoring screening, enabling risk-inducing interventions, maybe better targeted surveillance protocols. And if one would go deeper in the research aspect, one would see a lot of tumor-specific mutations. How could they also inform in the choice of targeted therapies like PARP inhibitors in BRCA mutated cancers or PI3 kinase inhibitors would act in their respective mutant cancers. So genetic information definitely, if it is grounded in Indian data set, is enabling a shift from a reactive to a proactive care, from a trial and error to a precision oncology setup. And it's critical that when we talk about the genomics, we talk about the Indian patients because they have a unique representation. The cancer comes early, comes aggressive, and our esteemed clinical colleagues would be able to spend more light on the kind of early onset that they see in their clinics. I'll stop here. Thank you.
Thank you so much for that answer, ma'am. Moving on to my next question to Dr. Surendra. So, radiation therapy plays a crucial role in breast cancer management. For younger women, what unique challenges and considerations come into play while designing these treatment protocols? So, you're on mute. Yeah.
Yeah, Simran, thank you. This is a nice question that you have put. And what my previous speaker, Madam, also highlighted, in Indian scenario, we get the incidence of early breast cancer, particularly at the before age 40, is around what we get. Incidence is definitely higher than that of the Western countries, number one. Number two, we are also, the biological behavior is very bad. They are very aggressive tumor, more chances of failure. And for that, the young person having long career, long period of survival, and also the family background and pregnancy, all these are a social factor also comes to the play. And radiotherapy is also one of the integral part for the multidisciplinary management in carcinoma of the breast in people less than 30 years. So considering all these things, what whatever treatment that we give, we should be very careful for the its side effects or the late-term toxicity. Like that, for example, I can highlight that if the patient takes radiation with conventional vaccination, there is more chances of fibrosis, more chances of the cardiac toxicity, more chances of pulmonary toxicity, and more chances of the family, particularly the ovarian ablation. So these are the social issues that comes to the play. For that, we should be very careful, and with that, the different technologies that are also to our hand, by it we can also reduce this toxicity. Like one example I'm giving you that to reduce the left side breast cancer, and when we give radiation to the left chest wall, then there is more propensity that there may be late-term cardiac toxicity like myocardial infection after a long period, or there may be pulmonary fibrosis. So we are having latest technology, DIBH, that with DIBH, that's a technique. We can also reduce the dose to the lungs and heart. Similarly, also we can change the fractionation schedule. So if we can change the fractionation schedule, we can also reduce the morbidity. Beside that, we also very careful when delivering radiation, particularly the hormonal therapy is also an integral part for the treatment of the breast cancer. There also, nowadays, we are also not going for the ovarian irradiation, the other drugs or surgical technology are there. So, Simon, the treatment protocol, when we decide for a particular cancer of the breast in younger people is definitely different than that of the people who are more than 50 years. So when you consider the treatment in early age, particularly less than 40, we see the toxicity aspect. We see how best we can achieve the treatment goal. And also another important, the second malignancy. So considering this, we can change our technique or we can also modify the radiation dose. By it, we can reduce the long-term toxicity or malignancy. Thank you.
Thank you for that response, sir. My next question is to Dr. Sharad. So, from a surgical oncology perspective, what are some of the most significant difference in treating breast cancer in women under 40 compared to the older patients?
Simiran, it's a very interesting question to, to inform the audience. So basically, people below the age of 40, they are very healthy, they are very fit, and they have got a good amount of cardiac reserve. However, the tumor or the breast cancer in younger women is mostly aggressive. The biology is aggressive. Mostly they are what we call the triple negative or the HER2 positive types. They are high grade tumors and they're quite aggressive tumors. So the general health of the patient negates the biology of the disease. So also, as far as surgical decision taking is concerned, we tend to be very aggressive. We tend to be a little more radical compared to when we are doing for older women. We tend to do a little wider excisions. We need to be a little careful about the cosmesis because most of these young women are very much aware of their self-esteem, their shape, their beauty. So we have to look into the factors of preserving the breast whenever possible, reconstructing the breast whenever possible, and giving a good quality of life. Also, when we are dealing with the younger people, we always do the genetic tests and all that before, because sometimes many of these patients may need a bilateral mastectomy. Many of these people might have a familial cancer. Most of these patients usually go in for neoadjuvant chemotherapy and before surgery. And the one factor which affects them is also about the fertility considerations. There may be people who are very young who are very keen on having children, which can affect our decision taking. Uh, so all these factors are taken into account when we are treating these patients of breast cancer in younger age.
Thank you for that answer, sir. Moving on to my next question, Dr. Dhup. Ma'am, how important is genomic data in understanding that why breast cancer in young women is often more aggressive, and how can this knowledge influence the personalized care?
Yeah, very important question, Simran. So, thank you to Dr. Desai and Dr. Senapati. They have actually defined the clinical representation of the Indian women with breast cancer. So, they are biologically distinct, often more aggressive, these cancers. So, that what does that actually mean? It means that the tumors are more likely to be hormone receptor negative, which is the estrogen receptor. There might be a higher incidence of HER2 positivity or the triple negative breast cancer, which is the most aggressive subtype. And by the time they actually come to the clinic, because as Sir said, they are already very healthy, they may reach a stage where they are already node positive or metastatic at the time of diagnosis. That means that they're coming at a very late representation. And at that time, these features lead to poor prognosis and a higher recurrence rate. So a poor survival rate as well. So the question is, why are these cancers more aggressive? Why is it coming to the Indian women so early in time? So the genetic data sets till now, with the very little information that we have now, says that it is a possibility that the younger women, the younger Indian women that are representing this early onset may have germline mutations, meaning they may have mutations that are driving genomic instability. BRCA genes are the most well known in that cohort, TO2 and etc. And that would lead to a risk of early and aggressive breast cancer. There could be also situations where they would acquire alterations due to their surroundings, their environmental factors, which are called as somatic alterations, like TP53 or CMYC. These are various genes that we routinely study in cancer, where there could be gene alterations, loss of some genes, overexpression of certain genes, multiple copies. There could be pathway activations or depressions, which would basically mean that the normal stability of the genomic stability of the cell is disturbed. And so it goes like completely out of control. Many assays like MammaPrint, Oncotype, PAM50, they give based on genetic profiling, risk stratification of patients, and how this aggressiveness can be used to tailor the prognosis, the prediction of chemotherapy benefits or treatment tailoring, which is very, very critical in younger group. Because if the patient is already resistant to a certain drug because of the genetic manifestation, then using those drugs are not going to give any benefit to the patient. They are only going to result into over excessive exposure to toxic substances. With emerging multiomics technologies, one could even reveal mechanisms of drug resistance, metastatic potentials, invasions that would later on be contributing to relapse. Another factor that Indian population is aggressively so showing. So it's important that the patient follows its longitudinal treatment and the aggression is subtyped at the very beginning so that the therapy can be tailored by the clinicians in a way that it can weigh the aggressiveness of the genetic profile versus the treatments that are available. And with the identification of India specific biomarkers, this gap can be expressed. Having said that, aggressiveness is very person centric. So one would need a kind of a gene panel which is specific to Indian patients, or I would say specific to a subpopulation of India, that would guide personalized care right from screening to therapy selection and also for the progression of therapy with, I mean, a breast cancer patient typically would come back to the clinic every 6 to 8 months, and the therapy keeps evolving as the treatment progresses. Uh, so it's critical that the aggressiveness is mapped and quantified with respect to its to the patient's genomic scaling. Thank you.
With that, ma'am, we understand that how important is the genomic data to understand why these kind of cancer are more aggressive in younger patients than the older patients, and what could be the factors leading to it. But thank you so much for giving your view on that. My next question is Dr. Senapati. Sir, could you share some advancements in radiation techniques that are reducing the side effects and helping young women preserve their quality of life during and after the treatment? Sir, you're on mute, sir.
Yes, the issue is like this. Whether the surgical oncologist, radiation oncologist, or medical oncologist, we treat the cancer patient. The main motto for our treatment is that our therapeutic ratio should be more than one. What it means? That means that should be maximum tumor control probability and also less issue toxicity, so that the therapeutic ratio should be more than one. So based on this, on the hand of the radiation oncologist, our main motto is to have the maximum tumor control and to reduce the side effects of the treatment. And that is particularly the late toxicity, the different modern technique that is in our hand, that is DIBH, that is deep inspiration breath hold. What it means? So when we use the latest technology, we can reduce the heart dose in a tune of 35 to 45% than that of the conventional one. Even also dose to the coronary artery, that can be reduced up to 20%. So that is the technology in our hand, that is the DIBH. Next comes that the proton therapy. Now the proton therapy are available in the country in 2 centers. With that also we can reduce the mini heart dose in a tune of 30 to 80 to 90%. Then comes the uh, different latest technology like in our hand, particularly the IGRT, sorry, then some distances. So that is IGRT, IMRT, and particularly this IMRT and BHIMA technique, what we follow in our practice, that exactly we can focus the radiation to the tumor side and also spare the normal surrounding structures. So almost all the centers in the country, they are following this IMRT and BHIMA technology. Beside that, uh, to irradiate the less tissue, like a patient has come in a very small lesion of less than 2 centimeter, 1 centimeter. So they are not necessary that we have to irradiate the whole of the breast. So for that, we can also go for the accelerated partial breast irradiation. Most of the centers, they are also following the accelerated partial breast irradiation. That means we have to exactly focus the radiation to that side and also spare the rest of the normal breast and also the surrounding structures.
So we cannot
Of the
hear
bed.
you, sir.
That in that period also we can boost with the radiation. And Nowadays, most of the people are working people. They don't want to spend 5 weeks for the radiation with the radiation oncology in a radiation oncology department. So for that, we instead of 25 fractions, we have also reduced the number of fractions of radiation, even 5 fractions only, so that we can also save the time of the patient as well as the cost aspect, and no necessary that patient has to come from a long way. So that is the fast forward technique also most of the centers they are following. And very important, it's a cosmetic aspect. When we give some marks or the tattoo on the patient surface, but nowadays the surface cat radiotherapy is available in our hand. So there is no necessity to put the tattoo on the patient surface. And all these latest technology are also available in most of the centers in the country. All the latest technology, and people are also taking this advantage. So this is the update for the radiation oncology in carcinoma breast, particularly for the young patients.
Thank you so much for that answer, sir. And very rightly said, nowadays we have all the latest technology available for the breast cancer patient in our country. My next question is to Dr. Desai. So you have treated many young patients out there, and what emotional lifestyle challenges do you often observe in them, and how can the healthcare team provide more holistic support to them?
Uh, so, uh, so in India, India is a different country compared to what we see in literature in the Western world and in other countries. In India, it is just not a disease. It affects the whole family. The breast cancer affects the whole family because the woman is usually the center of the whole family. So it is associated with a lot of social condemnation. There's a lot of associated with silent this thing, feelings. A lot of cultural barriers take place, and then there is God. We are all very religious, and then we involve God in everything. So apart from that, we also notice that the woman is the main housekeeper of the family. We are basically a male-dominated society. The male is not able to cook in many of cultures in most of the families across India. So I have seen my own lady patients. Whenever they are coming for surgery, they usually cook for the food of the for the husband and the children, and then she comes for surgery. Same way when she is coming for chemotherapy, she is starving herself, but she cooks for her husband and her family, and then she comes back to take chemotherapy in the hospital. So this is the basic problem in our country. So basically, we'll have to break the silence of breast cancer. We'll have to educate the whole society. We have to improve the information provided to both the patients, communicate with them directly, talk to them directly. Many times we keep the patients a bit confused. Sometimes you don't give them the correct information. Most of the information you gives to the caretakers for the family, but not to the patient. But that is not an appropriate way, especially even if the patients are very illiterate and uneducated. It is very important that we talk directly to the patients, build that morale, and then give the treatment. Secondly, we also look into the cultural factors, religious factors. We negate all the influences by all religious and cultural or traditional whatever the attitudes in the society are, and we treat them very, very scientifically. So this is how we usually do it. We usually also have role models in breast cancer. We have young now, a lot of survivors now. We ask them to talk to these new fresh patients, boost their morale, and then keep on treating them. We engage the whole families, and just don't like make the families support her, because it's a very important part of for the family to support this patient and just not condemn her to misery.
Yes, sir, very rightly said. Because in our country, we say that we are a male-dominating society, but the families are still dependent upon the female of the home, whether it is food, whether it is the basic necessity. So if a lady gets this kind of disease, the whole family gets disturbed, and I think that's what the holistic support and ecosystem we are talking about. That how much support is required from the family members, their support, their understanding, and their regular, this thing for the females in the family for regular checkup. I think that's the whole point here. So thank you so much for shedding light on that, sir. My question is to Dr. Suveera. Ma'am, do you believe that awareness around genetic testing and preventive screening is sufficient in India for women under 40, or there's a large gap we need to address right now?
No, I don't think there is enough awareness. There is a wide and urgent gap between awareness, access, implementation, and utilization of genetic testing. Not just with women under 40, but I would say the population at large. Like Dr. Desai clearly indicated, there is huge burden of cultural stigma, there is fear, there is misinformation, and there is a lack of will also from the women to leave the family behind at home and come and take care of themselves. So while mutations in BRCA genes and TP53 and all these names, if you go a little deep into Google, you'll hear them all the time. They've been circulating for last 15, 20 years, I would say. Uh, Statistics shows that less than 10% of eligible women, and by eligible women, I mean those who have a strong family history of any kind of cancer, uh, less than 10% would actually go for genetic testing. And this is when they have access to genetic testing. Genetic counseling is not integrated with our primary healthcare or reproductive healthcare settings. We don't have a national program where this would be one of the main driving factors to maybe under gynecological or reproductive healthcare settings where women could be at a very early age, maybe in the schools itself, they should be made aware that if there is something different in your body, something happening strange, you need to go and ask, which is something that Indian women don't do. We're not trained, be it rural, be it urban population, women don't ask questions for their own welfare. Then technique wise also, like for example mammography, which is one of the main diagnostics or screening technologies, it's not very effective under 40 because of the breast density. So one needs to follow a very patterned and focused screening strategy on high risk young women, maybe starting in their late 20s. But this is not something as a standard practice in India. Even when women who would like to go for genetic counseling, the system is already so overwhelmed that they spend almost all their day waiting for their turn, and that detests them from going back again. And so I would say we really need a national risk-based screening program where the high-risk young women are detected before they actually reach the late stage. The bigger problem with Indian women is that by the time they come to the clinic, they are already at a late stage where survival is a problem, where treatment is it's going to take more time, and the treatment has to be equally aggressive as the disease itself. So that's where we are lacking. So public education campaigns, integration of counseling services, and for the society, for the public, like Dr. Desai clearly said, we need the society to be educated, to be made aware, not to ridicule such women, but to support them so that they come forward and seek treatment. And it's not about just treating a woman, it actually is giving information to the next many generations to come, because she would teach her kids. And it's a very important factor. So if you educate a woman about a disease, you're actually educating the next generation about the risk factors, and that can be a very good strategy to address this issue in Indian context. Thank you.
Very rightly pointed out. But a follow-up question on this, we have to ask that we know how aggressive is this disease, and like you said, we also need this kind of aggressive screening for this particular disease, so that we do not pass on this to next generation, and we create that awareness. Since we know that we need mass screening at every level, at every step, whether it is late 20s or just to educate the school going girls or the college girls, and to have that screening camps in societies or colonies, or let's say a particular organization. What is stopping our country for having that?
A lot of cultural stigma, a fear, and the fact that the woman is the primary caregiver. The moment she steps out of the home, she's at least gone for 3 to 4 hours if she has to go to a hospital, right? The kids will be back. There has to be somebody to take care of them, to feed them, to take care of them. There will be old people at home who she needs to care, to provide the care. She's a basic caregiver to the whole family structure in Indian context. So for her to actually step out for her own welfare requires an educated society, a supportive society. We definitely need the data. We definitely need the Indian data set on which the therapies or early prognosis or diagnostic or screening tools could be made. But all this would just remain there on the books or maybe part of discussions unless the society is ready to adapt in their daily routines. If it becomes like a standard practice that you are of this age, your aunt or your uncle had this disease, why don't you go and get yourself checked? It doesn't mean that they would take a part of your tissue and you would definitely have to undergo a surgery. There is so much to do before you reach that stage. So why not lead a lifestyle which is dictated by the counselor, prescribed by the healthy diets, lifestyle changes, some preventive actions that the doctors can prescribe well in the clinic, and have a mindset to go there, to spend that time. And that's not possible without the support of the family. That's the biggest challenge.
I think that's the thing we forget about our caregivers in our home. That is the lady that she also needs that care. So thank you so much for pointing out that thing, ma'am. My next question is to Dr. Senapati. Sir, what role do you think multidisciplinary care plays? That is combining oncologists, radiologists, surgeons, and counselors in improving the outcomes for younger breast cancer patients.
Fine. This is a very nice question that you have put forth. So the treatment of cancer based on multidisciplinary approach. There is no I in a team. The first treatment is the best treatment. If mismanaged, then if there is failure, then the ultimate outcome is poor. So best outcome that we can be achieved, a patient is handled in a oncology institution where there is multidisciplinary approach is there, by which we can get the proper treatment and also the best outcome that we can achieve. I'm giving few examples. Let us think with the oncologist. Surgeon decided, yes, this is the best treatment. And if surgeon is not aware that, yes, this patient needs a adjuvant treatment, then there is more chances of failure. But in oncology team, the oncologists, they are fully aware that what is the necessity for the patient. So in a joint clinic or multidisciplinary team, we usually decide, yes, this is the best treatment for a particular patient. As for example, the medical oncologist decide what best chemotherapy are necessary after the histopathology report is available, and the radiation oncologist decide, yes, what best modality of radiation is necessary for this patient. And also surgeon, he is the prime persons, particularly for the breast cancer, particularly early breast cancer, that what type of surgery, whether we have to go for the most commonly the BCS or any implant or any prosthesis like that, they decide. Next comes that once we treat, the matter is not over. But before treatment, it is the very important the role of radiologist and the pathologist, because breast cancer less than 40 years, dense breast, their mammography has no significant role. And the MRI, particularly if that is BRCA1, BRCA2, then also MRI has a major role. And pathology is also very important, that the treatment of breast cancer depends upon the different pathological parameters. Beside that, the immunohistochemistry, and that guides us what type of breast cancer is this, and that guides us what the best treatment modality. So the key person, that the radiologist and also the oncopathologist, they have a major role. Yes, we did the treatment, but what is next? We have to keep the patient on follow, because the toxicity of the treatment, like the fertility issue, so they are the very necessary for the fertility preservation options. So that is the role of the fertility specialists are there. Genetic counselor has an established role, because we get a lot of, particularly less than 40 years, BRCA1, BRCA2 positive,
or P10 positive, and there is the established role of the genetic counselor, that how best the patient can get benefit. So that is the role of the genetic counselor. Sometimes the second cancers are there due to the treatment. So we have to keep this patient on follow-up. And very important is psychosocial issue, because the body image, anxiety, all these things that comes to the picture. So the overall quality of life are best handled by the psychologist as well as the counselor. And for the advanced cases, the pain and palliative care has a major role, because there where the point arises where we cannot achieve much, then there is the role of pain and palliative care is there. But pain and palliative care also the integral part from very beginning of the treatment. So in a multidisciplinary team, all these people are there, and they decide that what is the best treatment that we can adopt for the particular patient. So in oncology practice, multidisciplinary care is a must or mandatory, by which we can get better treatment outcome and also better quality of life. Because we the oncologist may treat the patient, but what best quality of life that we can give to the patient, that is important. The patient has come to the society, because what we see majority of breast cancer patients are young people, and they are well educated, working in different industry, and their cosmesis and also quality of life, that is also important. So multidisciplinary approach is an integral part of the cancer treatment. Thank you.
Thank you so much for that response, sir, and sharing that importance of how this multidisciplinary approach can help us treat younger patient more effectively. My next question is to Dr. Desai. Sir, breast cancer carries social stigma in many parts of India, like you also mentioned. So, how do you suggest that we build better community level awareness and encourage young women to seek help early?
Yeah, see, of course, almost every cancer is associated with a lot of stigma. I have seen patients who are not allowed to meet their own children, and I've seen patients who are not allowed to go to a marriage, to any religious function. That is the attitude in many places in India. And I don't say it's very common, but still it is there. And all that has to go away, because there is still a sense of some negative factors which take place. People tend to put the blame on religion, on God, for the disease, and they still don't trust the whole scientific system which is prevalent right now in your country. We also must know that to remove this social stigma, the whole thing, that the whole society has to be educated. It doesn't help just by educating one or two people. And then there are no avenues to educate the whole society. We cannot go and teach people about breast cancer, because relatively it is an uncommon disease. However, will tell you some very interesting points. I have a hospital, one in the poorer sector of South Maharashtra, and one hospital in the well-educated part of Karnataka. So, and where it drains to the well-educated and the rich people. What I have seen is that what we are doing, when we are doing treating patients for the poor patients, we are treating them at low cost. Patients mostly in the schemes, the Ayushman Bharat schemes. So a lot of patients come get treated without any hassles. They keep up their regular follow-up. They are very sincere in the follow-up. They sincerely take their treatment, and then their lives are saved. The message goes into the society, in their local villages, in the local towns, in the local gullies, and then they keep on bringing more and more patients, because they know the results are very curable and nothing happens to them. However, what I am seeing in the educated people, these people are well off rich. They are associated with a lot of stigma. They would say, "What will my neighbor say? What will my relatives say?" So then they try to hide the disease. And these are the patients who come, though they come from very educated families, well-off families, they tend to keep delay, and then they take multiple opinions, keep getting confused by themselves. Doctors and healthcare in our country is not homogeneous. Everybody has a different way to practice medicine. So they keep on getting confused, and then they end up with advanced disease, with negative results. Many of them die, and that ends up in a system wherein the patients have a very negative attitude towards the disease. Once that negative attitude flourishes in the society, then a lot of stigma continues to increase, and then these patients don't really, are not very morally built to take the treatment. So I think this example should be very important, that whatever we do, we try to uh, be very open and frank with the patients. There should not be any silence between the patient and you should communicate directly with the patient. We all believe that the poor and the uneducated patients do not understand much about the disease, but that is not really so. When you talk to them directly, they have their own feelings, they have their own thing, and they also know that cancer is a mortal disease and they want to save their lives. So they are also very worried about saving their lives. That is why they do not miss on the treatments. They do not skip on their treatments, especially since it's almost free everywhere in India now. So we have seen this occur. They take the treatment sincerely and regularly, and again they get cured. However, the stigma which is there, especially among the educated and the rich, is still very difficult to control, and that is where our problem is. And this has to be educated very strongly by saying and in giving more and more healthcare. This thing in the especially in the peripheries, in the smaller towns, smaller villages, we have to pay the doctors more, especially when they are going to the peripheries in the smaller towns and smaller villages. Only then the healthcare of our country will improve. Because unless the smaller talukas, the district places, they don't get good health care, then there is no point in some people doing very high funda surgeries in Bombay, Hyderabad, Bangalore. So it is of no use. The whole foundation of healthcare in small towns of our country should be good. Once that foundation is good, the awareness will automatically increase in our country. And once that awareness comes, people will come. Like I see the poorer people, they come with 1 centimeter lumps, very small lumps, and then they're still afraid that are they late because they know it would be cancer. That is how they come. But when I'm seeing that in the educated people, they only come with a burst open breast, which is fungating and there is bleeding and there is a lot of infection and foul smell. So that is what occurs. So if we have to improve our country, we have to have a good foundation, especially in the basic basis of our country. I mean, in the smaller towns and the smaller districts. And when the healthcare is good over there, then we can call ourselves a developed country as far as healthcare is concerned. Thank you.
That's very rightly points out that we need education at a very base level, at ground level, so that it does not spread to a dangerous disease. And whenever there's just a slight doubt, also like you said, they come up with even just with the smallest lump to get it checked on time. I think that's what the education we want right now, so that it does not reaches to a later stage in any part of our society. So with this we have come to end of our discussion, but before we close I have a last question for each speaker. I'll start with Dr. Suveera. Ma'am, finally, if you have to share that one urgent call to action for the future of breast cancer research and care in young women, what would it be?
I would say since cancer is a multifactorial disease, it needs multifactorial action points. And the two most important action points would be generate genetic literacy, awareness, and two, integrate genetics or genomics in care. I'm not saying that every patient should go and get themselves sequenced, get their whole DNA tested. That's not needed. For that, we are building a reference cancer data set. But the fact that there are options when you see something is wrong, go get checked, be aware of your options. Not just in the cities, in the rural settings, everywhere. Everybody has a right to live their life peacefully and in a healthy way. So, definitely awareness and an integrative approach with both genetic literacy and genomics in cancer care. Thank you.
Thank you for that answer, ma'am. Dr. Senapati, what would be your view that one urgent call to action for the future of breast cancer research care in young women?
Yeah, Simiran, you are having 2 points to be discussed. One is the research and care. And I am overwhelmed with the talk of Dr. Sharad Desai. What he has highlighted that we have to get the patient at early stage. Fine. Even also we get the disease at early stage, but we have to start the treatment and complete the treatment because the treatment is of a long duration. So I'm giving one of the example. In my state, I belong to Odisha. Here, most of the people are poor patients. But you may believe or may not, all the treatments, starting from the diagnosis, even also the molecular testing, all the molecular testing, and also even PET scan, all are free of cost. The patient should not pay a single pie, but patient has to come to the hospital. That's number one. Number two, that when all the modern technology are in hand of a clinician, so they can get the best treatment to the patient. But for that, the drugs, yes, all the latest drugs are also available free of cost, except the immunotherapy, because that is not yet implemented. And the second point, that patient has to take 6 cycles or 12 cycles of chemotherapy, and patient has to come from a very long way to the cancer hospital. So that is the dropout rates were also high. But it has been, the treatment has been disseminated. Actually, the patient has to take the first cycle chemotherapy in an institution, and the rest of the cycle chemotherapy has to be taken in a district headquarter hospital. And most of the district headquarter hospitals, the doctors are trained in treating with the chemotherapy and also the pain and palliative care. Terminally ill patient, how the patient come to the center and take the treatment in a center which is more than 300, 400 kilometers away. So the treatment has dissipated, and also it has been given at the periphery. Very important, money is not a issue. No money, no treatment. So that's not a issue. So government is there. Government, even the Ayushman Bharat, all the treatments are free of cost. I have remembered few years back, everything was money, and for that a lot of dropouts are there. Patients are coming to the hospital taking 1 or 2 cycles of chemotherapy, then there is dropout. So that failure rate is high. But nowadays the number of patient turnover in an institution has also increased, because a lot of patients are not taking the treatment and they are also deprived from the treatment. So that is a very positive point for the government, that money is not an issue. Government policy that we are with you, come and take the treatment. At least you have to complete the treatment not only here at a district headquarter hospital. So that is for the care aspect. But still there we get a lot of patients in advanced stage. What madam told, that very important, the awareness program. We have to our public. So who will carry the message? Not the clinicians. Clinicians have no time. So it is the social organization. They should come forward, and so they should be attached. And they also send the message that what are the early signs and signals of cancer. Till now, a lot of myths are there. What Dr. Sharad also told. Even also, I have seen a patient on today. She was being beaten by her husband and also removed from the house because she is suffering from breast cancer. But it's still there. So who will break this? Only the social organization, they can also break this message, and they can send this message to the public. Regarding research, a lot of new molecules are coming, a lot of changes at the genetic level. So a lot of new molecules are coming, and also we don't know where is the end to it, but we are expecting a lot in future. Thank you.
Thank you so much, sir, for that answer. My last question is Dr. Desai. So, your view that one urgent call to action for the future of breast cancer research and care in young women.
Yeah, well, I would just give a little more this broader view. See, when we talk about oncology treatment, cancer treatment, it is a kind of tertiary treatment basically. And if you look at the other tertiary treatment, like let us say cardiac diseases, neurological diseases, kidney diseases, see when it comes to a large kidney stone or a kidney transplant or a heart operation or a neurosurgical operation, the patient can go to travel 500 kilometers to Bangalore, to Bombay, to Delhi, to Kolkata, and then they can return back and then they stay. In oncology, it doesn't happen so, because the patient has to keep on visiting week after week, week after every 30 days, after 21 days, every day for radiation therapy. All these things really affect the health care system when you talk about cancer. In cancer, the cancer center cannot be away from the site, from the home of the patient. This is the basic essence which we all must understand. So when the government is planning, when the charitable institutes are planning, when anybody is planning anything, you cannot keep on having big cancer in centers in Bombay, Delhi, Bangalore, and Hyderabad. Like let us say in Orissa, most of the healthcare system is focused and centered mostly in Bhubaneswar and Cuttack. and I think Sambalpur or somewhere. But if you look at the many districts in Orissa, there are, they do not have real good access to cancer care. These patients, the poor patients, the tribal patients, they have to travel all the way to Bhubaneswar and Calcutta, to unknown, unfamiliar localities, unfamiliar cities, and then they have to get treatment, which takes a lot of both money and stress on them. So this has to be corrected as far as our government, or we, the society, should correct it. Secondly, we also must understand that the more you cater, and as I said in my previous thing, that the more stronger you make the foundation, the base, and you go on treating the smaller places and smaller towns, the more better our healthcare system will be. And it is not just only in cancer. You build a strong healthcare system in the smaller towns and villages. The healthcare everywhere in India, everywhere in the world, this thing is going to improve. It will naturally improve. Unfortunately, what is happening is that we are tending to do high-end things only in big cities, big things. We get a proton therapy unit somewhere, and we talk about a robotic surgery in the big cities of our country. These are not going to change the whole healthcare system in our country. We are still remaining a developing nation. See, we have the tallest statue in the world, but still we are a developing nation. We have got atom bombs. We are still a developing nation. We are one of the highest GDP. We're still a developing nation. But if you look at some other countries like Sweden, New Zealand, Israel, and all that, they are very relatively, if you look at them, they are very small countries. They don't have any high-end things to show. But then if you look at the healthcare, they hardly get to see an ulcer. They hardly get to see a lump more than 2 centimeters. And that is how their healthcare system is. If you look at in the United States, the moment a doctor wants to go to the periphery, he's paid more. He gets a lot of reimbursements. He is made more comfortable. He gets a lot of facilities. So if you provide healthcare facilities, more reimbursement, more benefits to healthcare workers who go to the periphery, serve the poor, then the whole system is going to improve. That is what I would say. Instead of trying to focus on trying to teach the society and change the society, we healthcare providers should have a different outlook of how we must change our country.
Very rightly pointed out, sir, and thank you so much for sharing your view on this. Now, I would like to thank each panelist present here for sharing your views, insights, and expertise with us on this special occasion, which is the Breast Cancer Research Day. As the topic is under 40 and diagnosed, because we are seeing more and more cases in younger women, which is alarming, situation in our country. And for this, we wanted to create an awareness through this session. And thank you so much for helping us, for shedding light on all the important aspects of this. Your contribution, your expertise matters a lot for us and for all our audience out there. Thank you so much, sir and ma'am.
Thank you.
Thank you,
Thank
you.
Simiran, and my friend panelists. Thank you.
Thank you. Thank you,
Thank you, sir.
everyone.
Thank you.